Good morning. This class is all about skeletal muscle relaxants. This is the first part of the two classes. In this first part, we will discuss about the few important points about the skeletal muscle relaxants. Those are acting peripherally. My name is Dr. Jobin, and about the introduction classes of skeletal muscle relaxants. So, what do you mean by skeletal muscle relaxant? As the word meaning indicate, these are the drugs or agents which relaxes or reduces the tone of the muscle. So what is the purpose of using these drugs? Mainly in surgical procedures. That means, for example, in an orthopedic surgery or a general surgery procedure, the surgeons, they need to get a properly relaxed muscle. Then only they can do a perfect procedure. That means, in case of a fracture reduction, they need to get an adequately relaxed skeletal muscle, or for example lower limb muscles. Then only they can do the procedure in a correct manner. So these are the main purpose. So these agents, they reduces the skeletal muscle tone, and which leads to paralysis. Depending upon the site of action, these agents can either act peripherally or in the centrally. Centrally means in the cerebrospinal axis. That means next one is peripherally acting. Peripherally acting means they can either act directly to the muscle fiber or act at the neuromuscular junction. And in case of a skeletal muscle contraction, the cholinergic transmission is the major transmitter, major important factor in the transmission of impulses in the neuromuscular transmission of skeletal muscle contraction. So this is the basic structure of a neuromuscular junction. We have a presynaptic nerve terminal coming. That means the impulses are coming through this nerve, and when the impulses are reaching in the near the synapse, they will releases the stored acetylcholine from the vesicles. That means we have different n number of storage vesicles are there, and when the impulses are coming, these vesicles, they fuse with the presynaptic membrane and releases the acetylcholine from there, and this released acetylcholine goes and binds to the acetylcholine receptors in the postsynaptic membrane. Here we have muscle end plate. So they goes and acting on the acetylcholine receptors, and they produces the postsynaptic potential, and this will produce an action potential, and which will be conducted. And after the action, this acetylcholine is metabolized by acetylcholinesterase enzyme present in the postsynaptic membrane. So here comes another question. We have two different types of acetylcholine or cholinergic receptors. We have muscarinic receptors as well as nicotinic receptors. But in case of this neuromuscular junction, the significant receptor is nicotinic receptor. And among the nicotinic receptor itself, we have two types, NM as well as NM. And in this, NM is the significant receptor in case of a neuromuscular junction. NN is mainly in autonomic ganglion. So coming to the few important structural features of this acetylcholine receptors, mainly NM receptors. This is the acetylcholine NM receptor. It has 5 subunits, that means 2 alpha units, 1 beta, 1 gamma and 1 delta, and there is a central pore. Central pore is a conducting for sodium ions. That means these acetylcholine binding sites are located on the alpha subunit. When the acetylcholine molecules comes and binds on this alpha subunit, there is a changes in the structural conformation. So this channel, central sodium transmitting pore is open, and sodium ions enters through the receptor, and there will be depolarization, and this depolarization produces the end plate potential and further action potential. So these are the few points I have already discussed. That means nerve action potential comes, it releases acetylcholine, which binds to the nicotinic NM receptors, and which leads to end plate potential as influx of sodium, depolarization. If the end plate potential is sufficient, which leads to muscle action potential, and there is a release of calcium into sarcoplasm for a muscle contraction to takes place, there should be release of calcium into the sarcoplasm, which initiate muscle contraction procedures, and this contraction will be carried out. And later this acetylcholine is hydrolyzed by cholinesterase. Then this repolarization cycle start taking place. Coming to the classification of skeletal muscle relaxants. Depending upon the site of action, we have peripherally acting as well as centrally acting skeletal muscle relaxants. And these peripherally acting agents, they are further divided into those act as neuromuscular agents, that means neuromuscular blocking agents, and directly acting agents. And these drugs which act at neuromuscular junction or neuromuscular blockers, they are further classified depending upon their type of action, includes into non-depolarizing as well as depolarizing blockers. And these non-depolarizing blockers are also known as competitive blockers. And among the directly acting agents, that means they act directly at the muscle fiber, includes dantrolene sodium as well as quinine. So first we discuss about the agents which act peripherally, either at the neuromuscular junction or they act in the directly to the muscle fiber. So among this, we first discuss about neuromuscular blocking agents. The neuromuscular blocking agents are further divided into non-depolarizing as well as depolarizing agents. Non-depolarizing, also known as competitive blockers. I will discuss in the coming slides about this, why they are known as competitive blockers. And they are further divided again into three classes depending upon their duration of action. That means short acting, intermediate acting, and long acting. The first one is long acting. We have d-TUBOCURARINE, Pancuronium, ROCURONIUM, Physiology, MIVACURIUM, galamine. And intermediate acting agents are MOA, ROCURONIUM, ATRACURIUM, cis-ATRACURIUM, ROCURONIUM. And the short acting agents like MIVACURIUM as well as d-TUBOCURARINE. And the second class is depolarizing blockers, and among this we have two main agents like Succinylcholine and decamethonium. But the only the Succinylcholine is the only agent which are used clinically. Decamethonium does not have that much use as compared to Succinylcholine. Coming to the mechanism of action of non-depolarizing blockers. As we said, they are mainly acting in the neuromuscular junction, and in the neuromuscular junction they act in the end plate of the skeletal muscle fibers. They compete with the acetylcholine at the binding sites, so they are known as competitive blockers. During the introduction, I have mentioned that acetylcholine is the major neurotransmitter in the neuromuscular junction. So these non-depolarizing blockers, they compete with acetylcholine to bind to the NM receptors or acetylcholine receptors. So they goes and binds to the acetylcholine receptor. So acetylcholine cannot come and bind to the acetylcholine receptor. So there will not be any depolarization, action potential or depolarization. So that means they compete with acetylcholine, so they are known as competitive blockers, and they also does not produce any depolarization. So they are non-depolarizing agents. They have affinity, that means they have the ability to bind with the receptor, but they do not have any intrinsic activity. That means they do not produce any action further. So they does not depolarize the motor end plate, and there will be paralysis of the muscle. Sometimes they blocks the prejunctional NM receptor. That means at the nerve ending. That means they leads to failure of release of acetylcholine also. That means most of the time they goes and binds to the postsynaptic acetylcholine, so that acetylcholine cannot come and bind to the acetylcholine receptors. And at mainly in high doses, they goes and binds to the prejunctional receptor also, so that acetylcholine is not at all released. High doses produces more intense blockade, and there are two important features for this non-depolarizing block. First one is fade phenomenon. That means On repetitive stimulation, these responses are progressively depressed. That means after giving a skeletal muscle relaxant, you are continuously stimulating a muscle fiber. That means you can see the responses are progressively getting lower. And there is another entity known as post-tetanic potentiation. That means during we are repetitively stimulating a muscle fiber, and at a particular time we applied a high intensity stimulus, that means a tetanic stimulation, and after you again apply the normal stimulus. That means at that time you can see a increased response. That means the increase in the response to a subsequent single stimulation. That is known as post-tetanic potentiation. The theory behind this is during the time of this tetanic stimulation there will be increased release of acetylcholine. So this high concentration of acetylcholine go and binds to the acetylcholine receptor, so that in the next stimulation there can be an increased response. So this picture shows the two important features that I have discussed in the previous slide. So this is the first one is fade response. That means the responses are progressively getting lower, and this red mark indicated tetanic response. After that you again applied a stimulus, there will be increased response compared to the last fade response. That is known as post-tetanic potentiation. Next we have the mechanism of action of depolarizing blockers. As the name indicates, these drugs they produce a depolarization in the muscle end plate, but this is not that much sufficient to produce a muscle contraction. That means they produce a end plate potential which is submaximal. So among these depolarizing blockers we have two main agents like succinylcholine as well as decamethonium, and this succinylcholine is the major clinically relevant drug. So this succinylcholine is a structurally similar to acetylcholine. That means it's an analog. So being structurally analog, this can easily goes and binds to the acetylcholine receptor and produces an impulse, produces an stimulus. So these agents have affinity as well as submaximal intrinsic activity. As earlier I said about non-depolarizing blocker, they have only affinity, no intrinsic activity. But these depolarizing agents, they have affinity as well as submaximal intrinsic activity. That means their response is they produce an activity which is not that much as comparing to the natural analog like acetylcholine. And these drugs like succinylcholine, it's simply hydrolyzed after their reaction by the plasma pseudocholinesterase. By their submaximal intrinsic activity, they open the sodium channel, which leads to depolarization. That means they are known as depolarizing blockers, and which leads to muscle fasciculation initially, and will further leads to flaccid paralysis. And the paralysis produced by the depolarizing blockers can be divided into phase 1 as well as phase 2. This phase 2 seen in high doses. That means if you are giving this high dose of depolarizing blockers for continuously, then which leads to phase 2. That means initially they produces a depolarization, and this persistent depolarization leads to receptor insensitivity. That means there is a desensitization for the receptor with acetylcholine. That means even if the acetylcholine is coming during the time of contraction, that receptor is insensitive to the acetylcholine, and the acetylcholine cannot produce any response. That means that's how they are getting paralyzed. During this prolonged depolarization, these sodium channels they behave like prolonged closed state, and this phase 2 blockade is more or less similar to non-depolarizing blockers. Initially the depolarizing agents they produce a depolarization, and during persistent stimulation the receptor gets desensitized. That means acetylcholine cannot bind. Succinylcholine, when we administer succinylcholine, initially there will be increased response. That means initially they produce a submaximal depolarization. So as a result of this, the response increased and progressively decreased. But when you giving a tetanic stimulation, after that there will not be any post tetanic potentiation. The responses are further low. And during the reversal, this reversal from the skeletal muscle relaxant effect mainly done by neostigmine. Neostigmine is a what agent? Neostigmine is a cholinesterase inhibitor agent. Cholinesterase inhibitor means they inhibit the acetylcholinesterase enzyme, though so acetylcholine metabolism is not taking place. Acetylcholine is available there. In case of a non-depolarizing blocker, that means they are competitive blockers. These agents binds to the acetylcholine receptor site and prevents the acetylcholine from binding to the receptor. So when you administer a patient on a non-depolarizing blocker with neostigmine, that means this neostigmine goes and inhibits the acetylcholinesterase enzyme, so acetylcholine concentration increases. This increased concentration of acetylcholine, they can overcome the non-depolarizing blockers at the NM receptors and binds to the receptor, and thus they produces the skeletal muscle contraction. But that is not taking place with this case of depolarizing blocker, because if the receptors are desensitized with the acetylcholine, there is no point in administering the neostigmine. Non-depolarizing blockers, we have to discuss about the general features. They are all quaternary ammonium compound, so they are highly ionized agents. They are water soluble, not lipid soluble. So we have to administer these drugs through the IV route, and these agents generally does not cross blood-brain barrier or placenta. Regarding the duration of action of this drug, so it said that those agents which are excreted through the kidney, they have a longer duration of action. For example, Pancuronium, d-TUBOCURARINE, ROCURONIUM, and next is these agents excreted through the liver, they have an intermediate duration of action. For example, ATRACURIUM, MIVACURIUM, ROCURONIUM, and the agents which are metabolized by plasma cholinesterase, plasma enzyme, they have very short duration of action, like MIVACURIUM. Coming to the pharmacological actions of these non-depolarizing agents, they first act in the skeletal muscle. It produces rapid muscle weakness, which is followed by flaccid paralysis. Initially, it acts on the small but rapidly acting muscle fibers. For example, the muscle fibers in the fingers, eyes. Next affected group of muscle are limb muscles, then neck, face, trunk, and last the respiratory muscle. And during the time of recovery, this all sequences taking the reverse sequence. That means the first recovering muscles are respiratory muscle. Otherwise, the patient will be in respiratory failure. The second site of action is autonomic ganglia. Autonomic ganglia, there will be an autonomic ganglionic block. That means autonomic ganglia, as we already said, it has a receptor, nicotinic receptor, N receptor. These receptors are blocked with the use of this non-depolarizing or competitive blockers. So which leads to autonomic ganglion failure features. These features are maximum with d-TUBOCURARINE as well as certain other agents, but it is said that newer agents, mainly like Pancuronium, they have less or absent autonomic ganglion blocking features. And the third pharmacological action is they produce histamine release. So the most common agent which leads to histamine release is d-TUBOCURARINE. This histamine is a powerful allergic mediator which leads to hypotension. Hypotension is due to smooth muscle relaxation. That means blood vessel smooth muscle relaxation, and which leads to then it further leads to flushing, bronchospasm. That means it produces constriction in the bronchial smooth muscle. Constriction here, bronchospasm, increased respiratory secretion. Then it's maximum for d-TUBOCURARINE, as well as they also produced by ATRACURIUM and MIVACURIUM. And steroidal agents, they have least histamine release. That means steroidal agent means that's coronium means rapacuronium, rocuronium. These are the steroidal. They have less histamine release. And if you want to prevent these histamine related features, you have to administer antihistaminics prior to the administration of the skeletal muscle relaxants. Then it's cardiovascular effect. Cardiovascular effect, there will be maximum hypotension. That is, this maximum hypotension is produced by d-TUBOCURARINE, ATRACURIUM or MIVACURIUM. This is mainly due to histamine release and autonomic ganglion block. And these certain agents like Pancuronium, they have a vagolytic action. That means they blocks the vagus action. Vagus action is mainly parasympathetic action. They blocks the parasympathetic action, so which leads to tachycardia. And the fifth site is gastrointestinal system. They reduces the tone as well as motility. It is mainly due to ganglionic blockade, and sometimes it leads to postoperative paralytic ileus also. Coming to each agents, this is the first one. This is d-TUBOCURARINE. It's a long-acting non-depolarizing or competitive blocker. It's the first clinically used agent. It leads to severe BP fall. This BP fall is due to prominent histamine release, ganglionic blockade, as well as there is decreased venous return from the paralyzed limb. The major factors are histamine release and ganglionic blockade, and due to its muscle relaxant, there will be decreased venous return. So these all three factors contribute to BP fall. Second agent is Pancuronium. This non-depolarizing blocker is having a good cardiovascular stability and less histamine release. It has a long duration of action because it is eliminated through the kidney. And this Pancuronium has a vagolytic action, so which leads to tachycardia and hypertension. And along with the vagolytic action, it also inhibits the reuptake of noradrenaline. That means this in the autonomic transmission, this action of the noradrenaline is terminated by the reuptake into the presynaptic vesicle. When you block this reuptake, there is increased concentration of noradrenaline, so it's continuously acting in the receptor and further produces action. Next agent is ATRACURIUM. It has an onset of action of 2 to 4 minutes, and as well as duration is 20 to 35 minutes. And for this ATRACURIUM is a very significant elimination technique. It's known as Hoffman elimination. It's a spontaneous non-enzymatic degradation. So this is the preferred agent even in case of liver and kidney failure conditions. That means this is metabolized mainly by Hoffman elimination. It's a spontaneous non-enzymatic degradation, and further few mechanisms like ester hydrolysis. That means this is possible, but the major route of elimination is Hoffman elimination. And this Hoffman elimination, they produce another metabolite known as laudanosine. Sometimes this laudanosine accumulated and lead to seizure. Next we have ROCURONIUM. This agent has a rapid onset of action which within 1 to 2 minutes, which is almost similar to Succinylcholine. This agent is having intermediate duration of action. Can be used as an alternative to Succinylcholine in endotracheal intubation. It maintains the skeletal muscle relaxant during the surgical procedures, and as well as to facilitate mechanical ventilation in ICU setups. It's popular because of its precisely timed onset and duration of action. Next we have MIVACURIUM, which is a shortest acting skeletal muscle relaxant. Not the shortest acting non-depolarizing blocker. The shortest acting skeletal muscle relaxant is Succinylcholine, that I will discuss later. This MIVACURIUM is the shortest acting non-depolarizing muscle blocker. So this agent, it's metabolized by plasma pseudocholinesterase, so that's why they are acting very shortly. But in certain persons with genetic changes, that means they do not have a proper pseudocholinesterase, they have an atypical pseudocholinesterase. So because of the presence of this atypical pseudocholinesterase, these MIVACURIUM like drugs are not metabolized. They are continuously presenting in the plasma, and they are continuously acting on the receptors. so which leads to prolonged paralysis, respiratory paralysis, skeletal muscle paralysis, and prolonged apnea. So in such a cases we have to continue the mechanical ventilation. This drug does have decreased histamine release and ganglion blockade, so it does not produce that much complication when comparing to the d-TUBOCURARINE, and usually does not require any reversal with neostigmine, because this is a very shortly acting drug. It can be in normal persons, it's metabolized by plasma pseudocholinesterase, so the usual cases does not require any reversal. And coming to the reversal of non-depolarizing neuromuscular blockade, we have the major agents like neostigmine and pyridostigmine. As you have studied in ANS, that this neostigmine and pyridostigmine, they are acetylcholinesterase inhibitors. Acetylcholinesterase is an enzyme which metabolizes acetylcholine after its action. That means this action of acetylcholine is terminated by the acetylcholinesterase enzyme. When this acetylcholine enzyme is inhibited by certain drugs like neostigmine or pyridostigmine, the action of acetylcholine is prolonged, or there will be more quantity of acetylcholine available in the synapse to act on the receptors. Okay, so in case of a non-depolarizing blocker, that means they are competitive blockers. They competitively blocks the acetylcholine binding site. When you administer neostigmine or pyridostigmine in such a patient, this agent increases acetylcholine concentration. So when the concentration of acetylcholine increases, they can shift the competitive block. So the acetylcholine goes and binds to the acetylcholine receptors on the postsynaptic membrane, and which leads to muscle contraction. Idurofonium is another cholinesterase inhibitor. There is another agent known as sugammadex. That's not commonly used for the clinical purpose. It's known as a modified gamma cyclodextran. This sugammadex, they bind tightly to the two agents, mainly in ROCURONIUM as well as MIVACURIUM, in a 1:1 ratio. That means they act like a chelating agent. That means they binds to the physically or chemically they binds to the binds to a drug and form an inactive complex, and they are released. These complexes are excreted or released through the urine, and which leads to decreased plasma ROCURONIUM concentration. When the plasma concentration of ROCURONIUM decreases, there will be further release of ROCURONIUM from the nicotinic acetylcholine receptors. So there will be reversal taking place. And coming to the depolarizing blocker, it's succinylcholine. It is the major clinically useful depolarizing blocker. It's also a quaternary ammonium compound with an onset of action 1 to 1.5 minutes. Total duration of action is 5 to 10 minutes. This is the shortest acting skeletal muscle relaxant. But you have to be cautious that when you have a question like the shortest acting non-depolarizing or competitive blocker is MIVACURIUM, and the next one is this succinylcholine is the shortest acting skeletal muscle relaxant. This succinylcholine is metabolized by pseudocholinesterase in plasma or butyrylcholinesterase in liver. And there is another important concept, that is a d-TUBOCURARINE number. d-TUBOCURARINE number, it measures the ability to metabolize succinylcholine. That means the same principle I discussed in case of MIVACURIUM. This succinylcholine is also metabolized by plasma pseudocholinesterase, and in certain persons with genetic changes, that they do have a atypical pseudocholinesterase. So this atypical pseudocholinesterase does not metabolize succinylcholine. So succinylcholine continuously acting on the neuromuscular junction, and there will be longer duration of skeletal muscle paralysis as well as respiratory paralysis. So in such a cases, if you have a doubt, you can check the d-TUBOCURARINE number. That means it measures the ability to metabolize succinylcholine. It indicates the percentage of enzyme is inhibited by d-TUBOCURARINE. It normally a person have 70 to 80%. That means he or she can metabolize this succinylcholine. And coming to the sequence of action of this succinylcholine. So sequence of paralysis, which includes neck, lymph muscles, face, jaws, eyes, pharynx, trunk, diaphragm, the respiratory muscle. That means this is a normal order and there will be a recovery in the reverse order. Next pharmacological action is it stimulates the ganglia. In case of a non-depolarizing blocker, they are autonomic ganglion blockers, but here the succinylcholine is a autonomic ganglion stimulant. That means they have a different action that you have to be careful. So stimulation of ganglia means they are stimulating the nicotinic endorphin receptor, because when I first discussing about this succinylcholine, I mentioned that it's a structural analog of acetylcholine, and it has affinity as well as intrinsic submaximal intrinsic activity. That's the same principle applying here. It binds as well as active here. This is not blocking. And this succinylcholine also do have histamine release. Because of its stimulation in the autonomic ganglia, it leads to tachycardia and rise in BP. And histamine release does not give that much fall in BP. So here we have a predominant effect is rise in BP as well as tachycardia, and mainly using for short procedures and those for excellent intubation. Coming to the adverse effect, it produces respiratory paralysis as well as prolonged apnea, mainly in case of pseudocholinesterase, atypical pseudocholinesterase, and hyperkalemia. Hyperkalemia means initially it produces a muscle depolarization and fasciculation, so there will be release of potassium from intracellular stores in the extracellular site, so there will be hyperkalemia, and this fasciculation leads to muscle soreness, and sometimes they leads to malignant hyperthermia, increased intraocular pressure, muscle dystrophy, masseter rigidity, and aspiration of gastric contents. About few drug interactions with this skeletal muscle relaxants. First, we have few agents which potentiate the actions of this skeletal muscle relaxant. That means they leads to skeletal muscle relaxation, like inhalational anesthetic agents like isoflurane, antibiotics like tetracyclines, aminoglycosides, polymyxin, colistin, calcium channel blockers, diuretics. These tetracyclines all they form a chelating or a unstable or inactive compound. That means they chelate the calcium. So calcium cannot bind to the receptors, and which does not lead to muscular contraction. And diuretics they produces a hypokalemia situation. That means hypokalemia further enhances the muscle relaxant action. Next, few agents which attenuate or inhibit the action of skeletal muscle relaxant. We have anticholinesterase, that means neostigmine, pyridostigmine, they reverses the neuromuscular blockers. Then anti-muscarinic agents, some very few, and thiopentone sodium. Thiopentone sodium is a barbiturate. So this is the end of this first part of skeletal muscle relaxant. So in this we have seen few important points about the skeletal muscle contraction. That means a presynaptic nerve terminal comes, then impulses coming, and there is certain release of acetylcholine. This acetylcholine goes and binds to the postsynaptic membrane acetylcholine receptors like nicotinic receptors and produces the muscle contraction. And we have mainly discussed about the agents which produces the skeletal muscle relaxant by acting on the neuromuscular junction. So we have two groups, non-depolarizing block as well as depolarizing block. So non-depolarizing blockers are also known as competitive blockers. That means they goes and binds to the nicotinic receptor. They have an affinity, not having an intrinsic activity. They only binds and blocks the receptor. So acetylcholine cannot come and binds to the acetylcholine receptor. So there will be muscle relaxation, and we can reverse this block by using neostigmine. Neostigmine is an anticholinesterase. It inhibits the cholinesterase enzyme. So acetylcholine concentration is increased. So increased acetylcholine concentration goes and binds to the acetylcholine receptors and leads to muscle contraction. And we have different agents here depending upon the duration of action. We have long acting, intermediate acting, and short acting. So we have MIVACURIUM, ATRACURIUM, ROCURONIUM, VICURONIUM. So few agents. Next group is depolarizing blocker. That means the agents we have succinylcholine as well as decamethonium. The succinylcholine is a structural analog of acetylcholine, binds to the acetylcholine receptors, and initially they produce a submaximal response, that means a fasciculation. So continuing stimulation which leads to desensitization of receptor, and there will be flaccid paralysis. So this block does not overcome by the help of neostigmine. And another important thing is there's some genetic variations. The persons with certain genetic variation does not have plasma pseudocholinesterase. They have an atypical pseudocholinesterase. So in such patient there will be prolonged apnea or prolonged respiratory paralysis, which is known as succinylcholine apnea. So that finishes part 1, and in the second part we will discuss those agents which directly act on the skeletal muscle fibers, and the remaining one will be acting in the central nervous system to produce skeletal muscle relaxation.